Good afternoon, and thank you for joining us for today's webinar. Healthcare stakeholders rely on credible, high-quality evidence for making healthcare decisions. That evidence could come via comparative effectiveness research. Recognizing the importance of this information, the National Pharmaceutical Council has been tracking stakeholders' perceptions of CER for more than 6 years to understand how much of an impact it's been having on healthcare decision-making. We started this survey at a time when the Affordable Care Act had just been signed into law, when the Patient-Centered Outcomes Research Institute was just being formed, and when CER, funded by the economic stimulus package that was passed by Congress and signed by the President, was just getting underway. Fast forward to today, now that all of those activities have matured. What do stakeholders believe now? What do they think about CER, its impact on decision-making, and other issues impacting the healthcare environment? To walk us through the answer to that question with the results of our survey, I'd like to introduce Kimberly Westrich. Kimberly is the Vice President of Health Services Research at the National Pharmaceutical Council, and for the last 6 years has been our project lead on this survey, which we have conducted in conjunction with Social and Scientific Systems Incorporated. After Kimberly's presentation, we'll hear from two special guest reactors who are with us here in the room today. Dr. Joe Selby, who is the Executive Director of PCORI, the Patient-Centered Outcomes Research Institute, and Dr. Lisa Simpson, who is the President and CEO of ACAD Health. They'll provide us with some outside perspectives on the survey results, and then we'll open up the discussion for questions from those of you on the webinar.
Thank you, Dan. As Dan said, this is the 6th year that we have conducted this survey on the CER environment and its impact on healthcare decision-making. We've been interviewing the same stakeholders each year. You can see them on the chart in front of you. The groups that we talk to are health plans and insurers, government, employers, researchers and academia, business coalitions, and trade associations. And this year we actually had a stronger response rate than we have in prior years, with a stronger response rate from the health plans and the insurers. So I do want to remind you, since we do have a slightly shifting composition each year, that can affect some of the trends that we're looking at. The unit of analysis that we look at is the organization. For all groups except for the researchers and thought leaders, there the individual is the person that we are analyzing. I like to begin with the end in mind. These are the takeaways I'd like you to get from my presentation. First and foremost, comparative effectiveness research is still important to our stakeholders. They recognize the ongoing significance of PCORI in these areas. Patients have a lot of roles in this space, particularly when it comes to establishing research priorities. AHRQ is expected to lead the charge when it comes to dissemination of CER research, but it's an area where stakeholders expect all groups to have a role and responsibility. As in former years, we see that the CER impact on healthcare decision-making remains a horizon issue, and we added a question this year about what could help CER have a greater impact on healthcare decision-making, and our stakeholders said that better translation of CER results into actionable recommendations was their #1 thought for how they could increase the impact. This slide shows data from all 6 years, from 2011 to 2016, how important CER is to our stakeholders. The purple section of the bar is very important. The green section is somewhat important. You can see it's continued to be important across all years. And I think Dr. Selby will have some comments about the importance of CER and how we can see that in the literature. I'm going to take a couple of moments to orient you to what you're looking at on this slide, because there are several slides that follow it that are a similar pattern. We asked a group of questions on the various areas and roles when it comes to CER, those areas being setting research standards, setting research priorities, translating and disseminating it, funding it, etc. For each one of these questions, we had groups that could play a key role over the next 5 years You see those groups going across the x-axis, the bottom of this chart, AHRQ, NIH, FDA, PCORI, academia, private health plans, the biopharmaceutical industry, and patient groups, which are a new group that we added this year to the survey. You'll notice that there are only 3 bars for each group, so I'm only showing you selected years from the survey. You can imagine if we had 6 bars for each of those groups, we'd have a big old mess up there on the screen, and you wouldn't be able to see any of the trends that I'd like you to see. So we're looking at the first year of the survey, 2011, the last year of the survey, 2016, and an interim year, 2013. This particular chart looks at the groups that have a role in establishing research standards over the next 5 years in the area of comparative effectiveness research. And what you see on this chart is one of the areas where we see the ongoing importance of PCORI, setting research standards. This isn't surprising when you think about all the work that they've done to put together the methodology reports. AHRQ also has a strong role in this space. This chart looks at who will have a significant role in establishing research priorities in the CER space. Here again you see PCORI and ARC and NIH with key groups. This is the first place where we really see the patient groups pop up. This is the space that patient groups were most strongly expected to have a key role by our stakeholders. This looks at the groups that will have an important role when it comes to funding and monitoring research. Again, you see an ongoing role for PCORI, NIH, and the biopharmaceutical industry have a strong role. What you don't see in this chart, since I'm only showing you selected years of data, if you could see 2014 and 2015, you would actually notice that PCORI was even higher in those years, 76 in 2014 and 81 in 2015. So there's actually a slight drop-off. Possibility for that is we do have so many more health plans that responded this year, and there may be some concerns about reauthorization. This slide looks at conducting research. It's very much still the domain of academia and the biopharmaceutical industry. I think Dr. Simpson may have some thoughts about other groups that perhaps could be on that slide conducting research. Now this question, you'll notice the bars are a different color. When it comes to translating and disseminating research, we added this question in 2014. We didn't have the foresight to include it in 2011. So again, you're looking at 3 years of data, but these are different years than you were looking at on the prior slides. This is 2014, 2015, and 2016. Here we see that ARC has the leadership role when it comes to translating and disseminating research. ARC and PCORI have a strong role. If you look at the faded out bars, though, you'll notice that almost every group is above 40. This is the only question where we really see that everybody's got an important responsibility in this space. Translating and disseminating research is really the responsibility of everyone. Now in this chart, you are only looking at data for 2016. So let me orient you to what you're looking at here. We asked stakeholders whether or not CER has had an impact on healthcare decision making or will have an impact. And they answered for 4 different time periods. They looked over the past year, that's the first bar, has it had an impact over the past year? And then they looked forward for 3 time periods. The second bar is over the next year. The third bar is over the next 3 years, and the last bar is over the next 5 years. The blue sections on the bars are no effect. The red sections are slight improvement. Green is moderate improvement, and purple is substantial improvement. So when you look historically over the past 12 years, there isn't much of an improvement in this space, according to the stakeholders. When they start to look ahead over the next year, 33% say, well, over the next year it can have a moderate to substantial improvement on healthcare decision making. But it really isn't until we move out to 3 and 5 years that you start to see a much larger share of the stakeholders thinking it will have a strong input. 78% in the next 3 years say it will have a substantial or moderate improvement. and 92% over the next 5 years. Now, since you're only looking at this year's data, you can't see what the past years look like, but if you're familiar with our survey, it looks very similar to this every year. So this is one of those things that I find interesting, how our stakeholders are continuing to reset their expectations and remain optimistic that there will be an impact on healthcare decision making. So why hasn't there been an impact on healthcare decision making? We decided to add a question this year to look at various things that could help increase CER impact. We looked in the literature to get our responses for this question, and we asked stakeholders to pick the top 3 things that they think would increase the impact of CER on healthcare decision making. Their number 1 recommendation was better translation of CER results into actionable recommendations. And that was followed somewhat closely by an increased infrastructure and resources for decision makers to use CER results. Something that's kind of interesting, if you look all the way down at the bottom, greater input into CER from patients and providers, we expected those to be higher, and they're actually a little bit lower, which ironically could be a good finding. I'm not going to spend a whole lot of time on these next slides, but I do want to remind folks that they're in there. We have 6 issues in the healthcare environment that we follow to get a pulse check from our stakeholders. I'm going to walk you through so you can see what you're looking at. Each one of these issues is an arrow, and the arrow is anchored on the left-hand side by a statement and the right-hand side by a statement. And the left-hand side is viewed as being less patient-centric, a less favorable environment. The right side is a more favorable environment. If you look at that top arrow, you can see a 1 and a 4 and a 7. Stakeholders were allowed to pick any number between 1 and 7 that in where they thought the environment was. And the issues that we look at here are the extent to which there are widely agreed upon research standards, the extent to which priorities adequately address treatment choices, the extent to which evidence interpretation is fully transparent and objective, and the extent to which value assessment is broadly focused. Those are the top 4. We've been tracking those since 2011. The next 2 we've been tracking since 2014, the extent to which real-world evidence is widely used, and the extent to which there's a complete evidence base. So this chart shows you the initial assessment in each of these areas. So for the top 4 arrows, you're looking at the assessment in 2011. In the bottom 2, you're looking at an assessment for 2014. And when we overlay 2016 onto those areas, we see that the top arrow, the extent to which they're widely agreed upon research standards, is the only one where there has been a significant increase and improvement in the way that the stakeholders view the environment. The other ones have pretty much remained significantly unchanged, so there are various opportunities to use more real-world evidence, bring more transparency to the way evidence is being interpreted, and to assess value from a more broad lens. So let me remind you what the key takeaways are from my section, that CER is still important to our stakeholders. The growing significance of PCORI has been recognized. Patients have an important role in CER, especially when it comes to establishing priorities. AHRQ is expected to lead the activities when it comes to dissemination, but it's a responsibility that really lies with all groups and all stakeholders. The actual impact of comparative effectiveness research on healthcare decision-making remains a horizon issue, 3 to 5 years, and stakeholders believe that better translation of CER results into actionable recommendations could increase its impact on healthcare decision-making.
So first of all, we're going to get reaction from Dr. Joe Selby of PCORI, and Joe, we'd love to hear your thoughts.
Thanks, Dan, and thanks, Kim. And hello, everyone. It's becoming a milestone in PCORI's life to attend this annual CER survey, and a pleasant one at that. And hello, Lisa. Nice to see you. Well, I mean, these results are very pleasing in a number of ways. I feel like what we see is that the community, as represented in these respondents, understands PCORI's role pretty darn well. Yes, we play an important role in developing research standards, in prioritizing research topics, in funding research, not conducting it, and a supplementary role in dissemination, as you said, along with others. A few things. Number one, with respect to the research standards, I just want to use this as an opportunity to say that our methodology committee, which develops and generates and disseminates these PCORI methodology standards, has just released an update, including a new section of standards on cluster designs, both randomized and observational cluster designs. And the public comment period is open just a little while longer till the end of March. So I would really encourage you to go to our website and take a look at the revised standards. It's not that big a list. You might learn something, as I did, and you certainly have a chance to comment. With respect to the finding that patients should have a role in research prioritization, that is the way we live our lives at PCORI. We talk to patients and patient organizations routinely in every stage of identifying and prioritizing these topics. But there's one group that I would really encourage who ought to be involved. They are involved with PCORI in research prioritization because they have a lot to say, and it would be interesting to put them on this survey next year too. And that is clinicians, particularly as represented by their specialty organizations. We turn to clinician specialty organizations a lot to understand what is the right question, what's the best way to ask this question, what will give durable information that will change practice. They're the ones that are doing the practice. So, and you might see changes in practice somewhat before you see certain changes in policy. So I think it would be very interesting to include those specialty organizations there. Similarly, in the area of dissemination, just as you said, Kim, the ARC has the leadership role in the PCORI Trust Fund legislation for dissemination. We generate evidence that needs to be disseminated. Dissemination is very hard work. ARC got a rather small amount of the overall pie for dissemination, and PCORI recognizes that it's likely going to have to lend additional resources just to get our own results disseminated, and that's very important to us. But I couldn't agree more that everybody on the, I couldn't agree with the respondents more, that everybody on the list has a role to play in dissemination. And in fact, I think they do play it. And I would add one group, again, the clinician specialists. Who better than the clinician specialty organizations who write many of the clinical guidelines for doing important work around dissemination. To the question about whether CER is beginning to influence practices, again, one thing I would say is that if we ask clinician specialists this question, and I notice they're not among the respondents either, they might notice the impact first. But I think I might have alluded to this last year, and ever since then I've been watching and actually measuring very crudely in my own way what I call the dissemination of CER. And I look at some of the leading journals in this country and elsewhere, the New England Journal and JAMA and the Annals of Internal Medicine, British Medical Journal, and Lancet, and see a steady increase in the number of studies, original research entries in these journals that are crystal clear comparative effectiveness research. So I have to bet that by this time, if we had a group of specialists involved, they'd be aware of the growing impact of comparative studies. It's simply the fact that people are beginning to appreciate that the comparative framework gives you more useful information than, for example, a framework of this versus a placebo. Now you know that it should be considered, but you still don't know whether it's better than what you've been doing in many cases. You don't know about it either for benefits or side effects. So take a look the next time you pick up one of any journal, but particularly those commonly read journals. and see if you don't start noticing comparative effectiveness research right up there. I think that whether we know it or not, and whether our respondents know it or not, CER is taking over a bigger slice of the publication pie. It's just the way that we ask and answer questions increasingly. It's not going to go away. And I think I'll stop at this point and see what Lisa has to say, and we'll have the best part, which is the question and answer part.
Right. So we will have the opportunity for questions coming up, but before that, I would love to hear from Dr. Lisa Simpson from Academy Health.
Thank you, Dan, and as always, thank you to the whole NPC team and Kimberly particularly for the survey itself. And it's great to be invited back and to have this chance to be with all of you and Joe. I would underscore what Joe said. It's just very helpful to have you do this for the field, to every year to sort of step back from the hard work of actually funding for Joe and others research and conducting research and trying to get research findings out for use, and sort of look at the big picture and see where are we, and are we getting to where we want to go, more importantly, in terms of impact and improving health outcomes. So as you know, Academy Health is the professional society for health services and policy research, and this sort of trend, or looking at trends and monitoring changes, is kind of what we do as well, and so I find this really fascinating. And so I want to comment on a few of the findings that you've sort of pulled out, Kimberly, already, and that Joe's commented on. The first is obviously the newest piece of the survey, which is the inclusion of patient groups as one of the response options. I think that what the respondents said, and the growing recognition that in CER, but increasingly throughout research, we can't just do this in isolation. We have to engage sort of the end user of our research, and that's often the patient and the family, but also decision makers, health plans, delivery systems. And so this sort of engaged scholarship approach is becoming far more common. At Academy Health, we have a consumer patient researcher roundtable that looks at these issues. Again, it's as hard as it is to get it started, Joe, it's even harder to make sure that all research is happening this way. And it's a new set of skills for a researcher who may have just been trained in a more traditional academic approach. So it's taking some time, but I'm glad to see this. And in fact, throughout our Academy Health has the upcoming Health Data Palooza, and we're delighted that NPC has partnered with us on that and has helped organize one of the panels. But again, getting patients included in all activities along what I guess I would call the research lifespan, from inception and conceptualization throughout conduct and then dissemination. I also want to comment on the question of standards, because as Joe said, the PCORI Methodology Committee has been instrumental in really pushing this issue of method standards. I'm delighted that the update is out, and at Academy Health and our Methods Council, we'll be very eager to review that. Haven't looked at it yet, but looking forward to that. And particularly pleased that it includes that additional chapter, because one of the areas we've been talking a lot about is how do you evaluate complex interventions. We've always known the world of clinical services is complex because you're dealing with real patients and real docs and communities. But with the amount of transformation that's happening in American healthcare today, the complexity seems to have only increased. And so really understanding how to still design robust interventions with robust evaluations and designs, whether they're cluster designs or other approaches, I think is a really important area for us to focus on going forward. Kimberly mentioned that I had a comment about sort of the who's doing research and who's conducting. So obviously, in addition to academics and industry, you had health plans listed, and far less respondents saw them as a site of conduct of research. But what we're finding increasingly is the amount of research that's going on in delivery systems and these new sort of hybrid entities of data analytics research organizations, the explosion of electronic health record data, the spurring by PCORI of PCORNet and the patient-powered research networks and the CDRNs, lots of acronyms that, PCORI, you have helped to contribute to the Washington acronym salad. But really, I think that delivery systems are also now also an important player in doing this kind of research. I also, one of the things about roles in translation dissemination on that slide, folks saw decreasing responsibility for academia. That was one of the sort of steady decreases. But I would actually say that we're certainly spending a lot of time trying to actually help academia and academic researchers do a much better job of translation dissemination. Now, that's not to say that we don't have a lot of sort of structural impediments. How research is funded, how, promotion and tenure processes, rules around peer-reviewed publication as opposed to, getting it out in an issue brief, all make this challenging, but I think the world is changing. And we also partner with NIH and also PCORI and the VA and others on an annual conference on dissemination and implementation science. And so I think there's an increasing focus on, getting the academic community to do this much better. And that's so it speaks to, if we don't do that much better, all of us, to your point of view, the new question, our impact will be delayed. If we aren't better at translation and dissemination, our impact will be delayed. And I'd say we've been focusing on this issue of research impact assessment recently and having some conversations, particularly with colleagues in other countries, Canada, Australia, the UK, and other countries seem to have gone further than we seem to have gone in this country on actually trying to assess impact of academic research in terms of real community, population, economic impact, and using that result, that measured result, in future funding decisions. So sort of talk about, I always like to say that we use behavioral economics for patients and providers, but we never apply it to researchers. And I think we could learn from our own work and think about how to incentivize research for more impact. I think PCORI is certainly doing that, but again, the big behemoth is the NIH, and I think that we can look to other countries who are maybe a bit further ahead than we are. Then on slide 13, again, your new question. What I clearly 59% picked the top was this better translation, but I actually think the second bar is really fascinating because it's 43% thought that we needed to increase the infrastructure and resources for decision makers to use CER results. So in our traditional frame, we think about research translation dissemination as a push function. We're pushing it out. We've got to get it out in more relevant ways, the right place, right time, right decision. But we think less often about the pull, helping decision makers, wherever they sit, know where to look, how to use it, how to evaluate science, to put it in context, because it's rarely one finding from PCORI or NIH or anybody that's going to change your decision. It's a body of evidence. And so, for example, we work with state policymakers a lot on that. In fact, have some support from PCORI to work with Medicaid medical directors because they want to know, how do I use evidence in my decision making? Where do I find it? How do I use it? So those were some additional thoughts. I guess I would end by saying I know it's a small sample, even though it's a higher sample than in prior years, but I would be interested to see if, even if you sliced it into two, divided the sample in half and put on one side those who were basically paying for care, so employers, payers, plans, purchasers, and the other side, the other respondents, and looked to see if there were significant differences in what they thought about the horizon issue, about whose responsibility it is, et cetera. Because I think those who have a lot of skin in the game in terms of paying for care, I'd really like to know what they think.
Thank you, Dr. Simpson. Thank you, Joe. And now we're going to roll right into our Q&A portion of the program, and I've already mentioned a couple of times how you can get your questions into us, and we have a few coming in, but I want to take the prerogative to ask the first one, and this is the first year, as Kimberly noted, the first year that we asked patients or involved patients in this survey. And it might look today like that was an oversight on our part 5, 6 years ago when we started doing this. But as I think back, because I was involved with our very first survey, the conversation, frankly, Joe, before PCORI was not about patients making the decisions about what gets studied. Where are we going to do this research? And that question, establishing research priorities. I bet you, if we had asked that question 6 years ago, patients would have been, barely on the radar. So the fact that they are polling at 50% today, I think, goes in large part to the acronym SALAD that Lisa referenced, and putting patients right at the center of your organization, Joe. So that must be heartening. So that's a commentary, but I guess I would ask if you
agree with that premise that the involvement of patients at the establishing priorities has really taken off in just the last few years.
Well, yes, it was an idea that was, I guess you could say, pregnant in the sense that all you had to do was just simply say it a few times and everybody got it. So somehow we were blessed with the name PCORI instead of other things we could have been called. And that put our board, it focused our board squarely on defining what that means. And once we began talking about it and doing it, we found that it actually did work. The patients were more than ready and they really contributed. The examples of how involving patients changes everything from the outcomes that you measure to the ways you gather informed consent to even sometimes the study design or the duration of the study are becoming more and more numerous. And we're waiting now to be able to demonstrate that getting the questions right by involving patients, other things that patients help you do, increase participation rates, recruitment rates to trials, that would be nice, right?
Yep.
And ultimately enhances the ability to take the results off the shelf and get them into practice, get them adopted. So we're pretty sure that the answer is that it will be. We understand that it's an important task that PCORI needs to establish, preferably in the next 2 to 3 years. That is, that engagement with patients and other stakeholders makes a difference. But we're confident, based on everything we've experienced, that we'll find that it does.
And Lisa, from the academic community, from the professional research community, are you seeing a lot more partnering with patient organizations from your community?
Yes, we are. And we're seeing the conversation shift, again, as it becomes sort of more of a default and an expectation that, well, who wants to use this research? How did you set up your research question and your aims? Did it involve patients from the beginning? So I think it's not just PCORI. That's part of the influence to the broader ecosystem of research, that people are expecting that. That being said, it takes more time. That's what we hear anecdotally. I'd be delighted to see an impact, study that says, how has this changed research, not just for the better, but also what are some of the things you have to think about in terms of consequence in how you fund research, because it does take more time. And depending on which community of patients you're working with, it takes time to build trust. And in fact, I've heard a quip, I think I actually heard it at a PCORI meeting, Joe, for the first time, which was that change happens at the speed of trust. And if you think about that, we're trying to change healthcare systems, patient, clinical practice, patient practice, health behaviors, and for that to happen, there's got to be trusted exchanges. And so it takes time, and that means it takes money in terms of funding research.
So here's a question that came in through the through the webinar. What percentage of CER studies use real-world evidence versus the percentage of RCTs that use RCT studies? So maybe, Joe, from the PCORI sponsored view, do you have a rough idea of the percentage
Well, there's a little bit of a what I consider a false dichotomy there, because I think there's such a thing as real-world randomized trials. So, and I think that's what we fund a lot of, and what we're aiming to fund more with, and see others fund, is PCORNet, which is a very large infrastructure, which one of its 2 tasks is to conduct fast, efficient, real-world clinical trials. But if the questioner means observational studies, uses of real-world data without an intervention, then I would say that in PCORI's experience, about 70% of what we fund of our CER is randomized. It's real-world, but it's randomized study designs, and about 30% at this point are what this questioner might call big data or real-world data, or what I would call observational studies, no intervention. A little bit surprising. I would have guessed it would have turned out to be closer to 50-50, but I think it just reflects the fact that our reviewers feel that getting a CER question right often requires randomization, because you're talking often about modest size differences.
Well, I know the pushback, if you will, 5 or 6 years ago, going back to the beginning of the survey, most people, or many people, thought you couldn't possibly do that many RCTs. They take too long, and they'd be too involved and too expensive. So now PCORI is some of your antidote for that, right?
PCORI is an antidote. The board saw the need for this very early on. We think that CER and pragmatic research are only going to get more and more common. The need for them is going to be more and more recognized, and you can't do them, as you said, you can't do them at the standard price of a randomized trial. One has to figure out ways to embed them more in clinical practice, to get broader participation, not to have it be a 1 in 10 or 1 in 20 participation rate, and to make the collection of data as efficient as possible, to take advantage of data that are already collected, like electronic medical record and health plan claims data, to do some of that work for you.
And Lisa, from your perspective?
Well, I think this conversation, this type of dialogue, happens a lot in our community, and I find that it's too often framed as an either-or, RCT or other, like observational or real-world, whatever term. And the reality is that it's really a continuum, and we need to apply the most robust methods possible for the question at hand and the time frame at hand. And this is a conversation that's not just happening in healthcare, but increasingly it's in all areas of federal policy, the push for robust evidence from the Office of Management and Budget in allocating federal budgets. In the Washington conversation is there. People want robust evidence, and I think it would be very sad if it sort of ended up as it's got to be an RCT or else, and it's really about how do you put mixed methods together to get the best question, the best answer to the question you have. So I think it's a dialogue that's going to continue, but the innovations in data that Joe's alluding to, I think, are allowing some creative thinking about how to reduce the costs of random assignment studies, how to leverage all these other data streams, so you're not paying for all the data collection you used to have to pay for in an RCT. Much of it is already collected, and you only pay for the random assignment and some of those things. So I think there's some innovation in research design that's also helping people think differently about a dichotomous choice.
Great. And again, a reminder, you can send questions in to our panelists here today through the webinar or through Twitter. Here's what question that came in from the web. How do you envision, so Joe, you mentioned clinicians, and perhaps next year including clinicians in our surveys. Clinicians play an increased role in this. How would you envision patients and patient collaborating with clinicians, particularly, I guess, specialty clinicians in CER studies?
Well, I mean, we do it a lot in our studies. If you look at for example, some of our large studies are called our pragmatic clinical studies. In every one of them, there will be one or more patient organizations and one or more clinician organizations of the appropriate specialty involved. So they work closely together. I think more generally, I think we're funding models of research that specialty organizations, patient organizations can learn from. I certainly think that clinician specialists recognize, just like payers recognize, a lot of CER questions. But whoever recognizes the question, one still needs patients involved in elaborating the study and conducting the study. So I think they're natural partners. I think in general, clinicians and patients get along quite well in planning meetings as well as in the office.
Well, and there's also a long tradition of practice-based research networks that have existed. I think family practice, Joe, was the first specialty that really got into that, wasn't it, with Aspen? I'm dating myself here. But and so I think we also have a tradition to build on as well. And again, I mean, this concept of, if we think about clinicians in delivery system, as the healthcare system itself consolidates and practices are bought up by larger systems, more and more, there are more and more opportunities for what we are calling embedded research, where these are well-trained researchers who are working within large delivery systems directly with clinicians and patients on questions that are of operational importance. So they're still fundamental CER questions, but they're of priority to the operations of that practice or multi-specialty group, et cetera. So I think there's...
I'll just say that in the last couple of years, we've held 2 planning meetings. These were related to PCORI, but we specifically brought health system leaders in, delivery system leaders, hospital leaders. And they, both times, very articulately expressed a need for the kinds of researchers who can understand the way that they speak and the way that they think and can appreciate the needs for research in a timely fashion, iterative research, maximizing the utility of a particular research project for all the learnings that it can give. And so I think we recognize, I believe ARC, the entity in the PCORI legislation that is charged with training the workforce for doing PCORI, also recognizes a need for more of what Lisa called embedded researchers. I happen to be a type of embedded researcher for a while, so it seems real natural to me. I mean, earlier in my career, it seems real natural to me, but I think we're seeing it more and more, and I think it fits well with the idea of getting all the stakeholders involved in the research in an ongoing way.
And if I just could comment, Dan, also Academy Health is partnering with ARC, with PCORI, and the Robert Johnson Foundation to commission a series of papers to look at sort of what is the training for the workforce of the future. And it's going to take into account this sort of where are researchers now, what settings, what kind of employment, what kind of work do they do, and what does this mean for the training of researchers going forward? What skill set, we have a set of core competencies in our field, how do they need to be updated or changed for the future for this new kind of work that we're doing? And obviously, patient engagement, clinician engagement is part of that dynamic.
So this next question is one I'm positive I asked last year and probably the year before that because it is an evergreen, I think, in the survey, and it's basically that CER is a horizon issue and that we're going to see the tangible results from comparative effectiveness research studies are going to be seen 5 years down the road. Well, that's what they were saying 5 years ago, and that's what they're saying today. So when do we get to the horizon, Joe and Lisa, or is it always going to be just outside of our grasp, or would you argue we're there now and people just don't realize it yet?
My sense is that's why I'm kind of trying to plant the seeds every time you ask that question each year. So we come back a little stronger. I'm definitely stronger this year than last. I think CER results are showing up in the literature very prominently, and I think maybe we should put our heads together about how we do begin tracing some of that CER and the impact it's having. My hunch is, I don't think it's necessarily easy, but I think that we could find more impact. It's sneaking up on us, I think.
Because these are not random people off the street that we're surveying. These are the people who would know. These are thought leaders.
The other thought I had, I've already said it, but if we might be at the point where clinicians in various specialties are more aware of the impact it's having than the policymakers. It may not have quite gotten to their level. The blockbuster kind of studies that could guide their decision making might not have been done. CER is just being applied to every thing. Two surgical approaches.
Right.
The length of time that an antibiotic is given around surgery. Those kinds of things. Important questions, but not going to make it up to the employer or purchaser or the payer.
Right. Well, so again, you're right in pointing to the practitioners, the clinicians, particularly in the specialties, because they're reading their professional journals, which is where this work will be published, and the folks on the Hill, for example, or elsewhere in town aren't doing that. First round. Any comments, Lisa, on the horizon issue?
Yeah, I guess I would interpret it when we talked about this a few years ago. I think the initial enthusiasm, people started realizing, gosh, research takes time, and it's not going to happen in 3 years, and so the enthusiasm got tempered by some realism. And I think the reason it's still horizon is that, while there's been a lot more research funded, it's only just appearing, in the last couple of years in journals. And, I don't think it still takes that 17 years to get 14% of research into actual practice, but it does take years. Yeah. And so from the journal to actual transformation. And so the point, I think, now is we're also all recognizing that has to be a very active process. The translation dissemination is not a passive process. You have to focus on implementation strategies and incentives and actively get research findings into practice. And so, to Joe's point, he was, I wonder if, you were alluding to, or I was hearing you say, we need to start threading, following threads of research to see how they're being used and actually try to look at examples of use. This is not easy, but I think it's going to be important, particularly for 2019.
Yes, this is an interesting question that's just come in over the web, and it's really at that confluence of comparative effectiveness research and the new President's Initiative on Personalized Medicine, PMI, Personalized Medicine Initiative. And so thoughts on how to get subpopulations more involved in comparative effectiveness research so you can kind of sync up with this priority here in town.
I mean, I think there's a really close link between precision medicine as a new research initiative and comparative effectiveness and the work that PCORI does, and it's two ways. Number one, every time we fund a CER study, we ask applicants to tell us which subgroups they're going to look in and how they are going to look for what we call treatment heterogeneity, or that's what you call it too, now that I'm recalling the conference you sponsored on that topic. But that's an important part of CER. It's actually called out in our founding legislation that we should be looking for differences in treatment effectiveness, and we are. And those observations point the way to patient subgroups who are benefiting, and also, very interestingly, to patient subgroups that don't appear to be benefiting. And so that's fertile territory for new clues about, how one treats particular conditions. Now, on the other side, as precision medicine is generating its new approaches to diagnosis and treatment, its personalized approaches, I think there's a real role for CER in seeing how this plays out in the real world once they get to market. It may be that these personalized treatments work only in the target population. It may be that they actually work for a broader range of people without that particular marker that you thought was the secret. It may even be that they work for other conditions. So there's a role for real-world comparative effectiveness studies of precision medicine products, just as there is a role for CER in pointing to precision medicine questions going forward. So I think they're part and parcel of the same thoughtful product development process.
Comments on that?
Well, I guess I would comment that just as patients have biological heterogeneity and different reactions and outcomes to various therapeutic interventions, so do they have variations in the context of their lives, the environments they live in, their socioeconomic conditions. And so as we think about personalized medicine, we always want to come back to it's personalized not just in terms of your genomics, but personalized in terms of the total human being and their life experience, because all of that is going to influence treatment adherence, treatment outcomes, et cetera. So I think continuing to frame it from a broader perspective of personalized, taking every part of the patient's context into account.
So this question is off of the webinar. And Lisa, why don't you go first on this one, if you could. So payers clearly appreciate CER, but also would be interested in seeing the cost-benefit analysis included, which Joe has some prohibitions around in the statutory language at PCORI. But do you think that the dissemination and uptake of CER studies might be more enhanced or more rapid if the data included some cost examination or bring cost of care into the equation?
Well, yes. I think costs are a very critical dimension, not just for policymakers or payers and plans, but for patients. I mean, if you think about coverage, health insurance coverage today, many more patients are exposed to significant copayments, and as the saying goes, have a lot of skin in the game. And we're really trying to push for transparency and support consumer and patient choice. And, we all make that trade-off of what's the quality and value of the service I'm going to receive at what cost. And so I do think it's really important to try to understand the cost dimensions of treatment options. Again, I can just reflect from my personal experience as a breast cancer survivor. wanting to know the treatment options I had, but also what that meant in terms of cost, not just dollar and cent cost, but disruption of lifestyle, cost of dislocation, getting treatment in another setting, and putting that all into consideration influenced my treatment choices. And I think to the extent that PCORI can take that broad view of the frame of costs and look at the impact on patient treatment outcomes, I think,
And I think
doing what he can.
We actually do instruct applicants that we're very interested in out-of-pocket patient costs and resource utilization and other, what Lisa might call sort of other costs to patients. So we're very interested in all of those because those are really very patient-centered, patient-relevant outcomes. We don't tend to measure costs to delivery systems or payers because those costs are not very generalizable, from one setting to another. They can vary a lot. They also change rapidly over time. They don't tend to be stable over the several years that it would take to do the study. And different people have different perspectives. The biggest deficiency, I probably said this every year we've been on this call, but the biggest deficiency in anybody's cost effectiveness analysis or value equation is that they don't have information on these important outcomes, clinical outcomes and outcomes that matter to patients, including those ones that Lisa was just mentioning, the cost of transportation, missing work, child care, all of that kind of
caregiver impact.
Caregiver impact, all that's of interest to PCORI.
So this person is determined to get this question in because it came in both via Twitter and on the web. But Joe, definitely targeted to you. Will PCORI CER results include the number needed to treat for options when it is appropriate?
Sure. It's a practical piece of information. It's a nice way of translating a relative measure, like a relative risk, into something that patients and clinicians can make better decisions, information that they can use more effectively to make decisions. So yes, I think it's great measure.
Kimberly wants to just mention something here.
Oh, I wanted to mention that we do have a chart pack available on our website that has all of the years of data. In most of my slides, I just had selected years of data. And for folks who are interested in seeing trends over all 6 years, we do have it on the website and available to you.
Well, okay, I'm going to include this one as the probably the last question, as we're about 90 seconds on our target time. But I'm going to ask you both to predict the future, as I predict we'll be in this room again next year about the same time doing our 7th CER survey, and I look forward to that. But if you could predict the future, what changes, based on what you know today, or Joe, based on what you know is in the field or study-wise right now, what changes do you think we might see when we're engaged in this activity next year? Any thoughts on that?
Well, I can just hope that, and we might be able to do some work in the intervening 12 months, but it would be good to begin demonstrating some wins from the CER that we publish or that is being published by with funding from a lot of sources, from industry, from NIH, and others. So I hope that we see the beginnings of an appreciation that CER is beginning to affect decisions. Now, I think we'll only see greater growth in things like the importance of involving patients in the conduct of research, as well as in the research prioritization and dissemination. If we add clinicians, I think that'll be interesting to see what this group of respondents thinks about clinicians as well.
Lisa, final word?
I think we're going to see much the same, but I think even more emphasis on the translation dissemination. That's a new focus. That one question, that spoke to that. But I think people are, they want to use it, and so I interpreted the, more focus on translation as they think it's out there. They just don't think they're getting it.
And they might be right.
They might be right, exactly. And so I think that's an area where we can all focus our efforts over this coming year and maybe see some different responses.
Good. Well,
Actually, I'm going to take the final
Oh,
one.
crystal ball from
Yeah,
Kimberly.
when I look out towards the next year, one thing I've really clearly heard is we don't have the provider groups in here. So while we added the patient groups as a response option, it would be great to add the provider groups. And if it's possible to add a secondary sample, it would also be great to go to the patients and the providers, the ones that are using the CER evidence, and see what their perspective is. So if we do have an opportunity to delve into that, I think we would see some interesting trends.
Good. I think we're already rewriting the survey a little bit for next year, but that's very good.
Always thinking.
Always ahead. Well, excellent. Thank you. That does conclude the webinar for today, basically right on time. So I want to thank Dr. Selby and Dr. Simpson and Kimberly Westrich from our team here at NPC for participating, for conducting the webinar on comparative effectiveness research. Thanks to everyone on the line. We had a very good attendance online participating today and some excellent questions. All of the materials that you have seen and the slides, for example, are available on our website. That's npcnow.org/CER Survey 16. So thank you very much and happy Pi Day. It's Pi Day, 3.13, March 14th.
Oh, okay.
Bye, everybody. Thanks.